Hi, everybody. This is Geeta Rao. I'm a dietitian, diabetes educator, and I do work for Sutter Health, Palo Alto Medical Foundation. And I would like to thank all of you for joining into this webinar. And before that, I just wanted to talk a little bit about, give a little background about myself. I am, like I said, certified diabetes educator. I'm involved with Sweet Success programs, and I'm one of the board of directors with the Sweet Success Express and also the other affiliate programs. And today's webinar is focused on exercise and breastfeeding. So there's lots of questions that come about, how much to exercise and what is good during breastfeeding or oral medication. So I'm going to try to touch a little bit on all those aspects, but so please bear with me. All right, just to start with the disclaimer, this webinar is considered a resource, but does not define the standard of care in California. Attendees are advised to adapt the guidelines and resources based on their local facility's level of care and patient population served, and are also advised to not rely solely on the guidelines presented here. The recommendations are based from the CDAPP Sweet Success Guidelines for Care. New or updated information is verbally discussed throughout the presentation, and I have nothing to disclose. So if you were to see the slides, my slides are kind of divided into part 1 and part 2, because my focus is going to be on exercise, which is a part 1, and second part is going to be breastfeeding. So exercise and activity. So we all know that exercise is a tool to control blood sugars, and exercise will lower blood glucose if adequate insulin is available. And it is especially useful after meals in GDM to help use available glucose from the meal to minimize the blood glucose excursion. So this is a neat little slide that you see is an impact of exercise after the meal. If you look at the graph, it starts about the meal start, like at 8 o'clock, and from an hour where we tell the patients to check the sugars, and then 2 hours. So you can see that basically the slide is showing is a simplified demonstration of how exercise can impact the post-meal blood glucose rise. And walk right after finishing the meal is perfectly fine as the blood sugar is rising. So if you look at the dotted line and you see the start of the meal and you finish the meal at 8:25, and the sugars start to rise within an hour and then kind of drops. But if you look at the dotted line and if you were to exercise, you can see the sugars are looking a lot more better. So it's kind of a nice little slide, and you can use it to show it to your patients too, because many times when they look at it visually in a graph, it makes much more impact and say, oh, actually it does make a lot of difference. Now, exercise benefits for maternal benefits. So what does it do? Exercise during pregnancy, it increases insulin sensitivity, increases glucose utilization, and improves carb utilization, and decreases back pain. I know during pregnancy, as women advance in pregnancy, they tend to complain a lot about back pain. So when actually you're walking as much and being active, it helps you reduce the back pain. It also improves mild to moderate hypertension and may prevent excess weight gain, although we want to make sure that we're not telling them an intentional weight loss. But if someone has a lot of weight before pregnancy, we are talking about slow and steady weight gain. And also it helps with decrease of preeclampsia. Now, what are the potential risks? So as you can see, the risk is always risk for hypoglycemia. I think the risk for hypoglycemia is more pronounced with someone who's on medication or insulin, but there are times where women are on diet and you actually could see hypoglycemia, where I've seen in my practice where women are actually walking 45 minutes to an hour. I know it sounds like a lot, but there are some women who really, really want to walk a lot, to anything to do to avoid insulin. So you could see the risk of hypoglycemia going a little bit higher there. And also the blood pressure increases may exaggerate, may make the pre-existing long-term complications worse. And also there's a potential for musculoskeletal injuries. So one of the things that I want to focus in the slide is when an individual is sick and they exercise, this can still increase the blood glucose level, so which could be a lot more with pre-existing diabetes. So keeping in mind, all these facts are touched upon when we talk to the patients about exercise. The contraindications as identified by ACOG for exercise is pregnancy-induced hypertension, preterm rupture of membranes, preterm labor during the prior or current pregnancy or both, incompetent cervix or cerclage, persistent second and third trimester bleeding, and I see a lot of it. Some of my patients coming with this where we have to absolutely go with OB recommendation for anything that's contraindicated in terms of exercise, and also intrauterine growth restriction. Now, teaching points for exercise. As a provider, we always want to make sure the reason, I always tell them when I'm going through my first class is exercise, I call it as invisible insulin. It's as important as insulin. So many times patients don't have time to walk, but they don't want to go on insulin either. So I kind of give them two options, maybe not the right option, but I say, you could walk 10, 15 minutes, or you also have 10, 15 minutes. Probably you want to keep that time to inject insulin. That's, I will start walking. So, emphasize the importance of exercise in controlling your sugars. So exercise does play an important role in attaining and maintaining target levels of glycemia during pregnancy in women with gestational diabetes. So regular light exercises like walking for 20 to 30 minutes every day is a rationale component of the initial management regimen, regardless of maternal glycemia. So always encouraging walk. Well, many times women come by and they say, I don't have the time to walk. So I would say I would take any minutes of walk that you can do any time of the day. So that still helps you control your sugars rather than no walks at all. And it is prudent to advise a pregnant woman to stay well hydrated during exercise. Wear loose, because one of the things that could happen if you're not hydrated, you could end up with a lot of dehydration, and that could make it worse along with the pregnancy complications already, or the symptoms already. Also wearing loose clothing, and avoid high heat and humidity as to not overheat. Now, what are the goals for so individualized exercise recommendations are based totally on assessment. So what are we looking at? Exercise, how much and when? So this is always a question patients ask, is like, can I exercise before meal because I don't have time, or can I just exercise any time of the day? And like I said, it's very individualized based on the need. So you could be having a woman who is probably working graveyard shift, or someone who's just a homemaker, or someone who's, really busy at work with a lot of meetings. So individualizing is the key. But recommendations are normally after meal, because it always lowers the post-meal values, like we saw in the graph that kind of showed how the sugars kind of start to spike after eating, and 1 hour, which is the most spike that we see. Before meals, it does lower post-meal and pre-meal values as well. So women are welcome to walk before and after if they wanted to. That's perfectly fine. Daily activity is recommended, but 3 to 4 times per week is acceptable. And this is someone, women who come in to say, I'm just really active, like let's say you had a woman who's working in a hospital, who's a nurse, or who's really walking up and down. So we could consider that as a daily activity, and she is being active. But we still want to recommend at least 3 to 4 times per week is acceptable. So you have to really, like I said, base it on individual case. And some women use exercise to control specific needs. So one of the things I really want to point out here is a bit from my experience. Some of the women do come and they say, oh, you know what, I'm going to wait till 1 hour after I eat, and I'm just going to look at what my sugars look like and then start walking. So is that a right way to do it? I would say no, it's like cheating. The reason is, if you were to be checking your sugars, then most of the time your sugar starts to look okay. But as you advance in pregnancy, the insulin resistance goes up, and you can see your numbers spiking. So if you were to be seeing normal numbers like under 130 most of the time, and let's say today you walked and your number was like 150, and you panic and you start walking and your sugars start to drop, then you're kind of happy. Yeah, I walked, the sugar came back to normal. But not realizing the fact that 1 hour peak, which does most damage to the baby, and the sugars are already gone to the baby, and the damage has already happened at 1, in spite of you walking at 1 hour. So I always tell women that if you're trying to wait for like an hour and see what your numbers look like and walk after that, you're still running a risk of some complications. So I highly recommend, some women need a little bit more extra minutes after a certain meal, like dinner or something. But that's what the providers have to tweak and let them know as to what is an appropriate amount of time to walk. And duration normally recommended is 15 to 20 minutes post-meal with 60 minutes of daily total. But highly recommended post-meal of 15 minutes, which is shown to help lower sugars. To continue with how much of an exercise. So 30 to 60 minutes after meals do help blood glucose levels. Like I said, some of my women do walk a lot. Typically, recommendation is 15 to 20 minutes after main meal every day. Now, precaution, or when arm or leg is used for insulin injections, because it runs risk of hypoglycemia. Because when you inject in the muscle uses up the insulin, it releases insulin way faster, and you tend to use up that insulin release as happening, and you can end up with hypoglycemia. So that's what we always talk about, abdomen being the most accurate site for injection than arm. But sometimes we have had women who have injected in the arm or the leg because they were, having reactions in the stomach, like with bumps or blisters, or they just didn't want to do it. At that point, you have to really let them know about the risk of hypoglycemia when it's injected in the arm or the leg. And always when with hypoglycemia, using Rule 15 to treat, Rule 15 being if your sugars are running low, I usually say I don't even wait for 65. If you're running low, maybe like in the 60s, and start feeling like low sugars. And if you're in a position to check your sugars, and if your sugars are dropping down, then you consume 15 grams of carbs, instant carbs, wait for 15 minutes, check your sugars back up again. Normally your sugars should have bumped up by 15, 20 points. That's what we call Rule 15. And for women with type 1 diabetes, exercise post-meal with bolus insulin on board can result in serious sugars. So one of the things that I talk to type 1 diabetics, that when you inject insulin pre-meal, for example, Humalog, Novolog, it stays in your system 4 to 5 hours. And when you're walking, there's still insulin on board. And if women are walking a lot, and they just have to keep in mind that this insulin is being released every hour. So it can end up with some serious low blood sugar. So I would be extra cautious with someone who's type 1 diabetic to make sure they have instant sugar on board, like when you're walking, and check the sugars a lot more often. The types of exercise. What is perfect? This is one of the questions that a lot of the women ask is, can I be doing whatever I was doing before, or do I really have to just walk? So aerobic activities that minimize the risk of balance loss, like brisk walking, stationary bike, swimming, are all recommended. Avoid any high-impact exercise. So high-impact exercise meaning, so what is a high and a low? Low impact, if you've got both the feet on the ground and it's exercise, where like low impact aerobics, where you're actually not taking your feet off most of the time, both the feet. High impact, where both the feet are not always on the ground, but it's, some examples could be jumping and leaping and hopping and skipping. That's something that you want to really try to avoid during pregnancy. And avoiding exercise in lying down position after the first trimester. And also prenatal yoga. And it's perfectly okay as long as it's guided by someone who, the yoga instructor who is experienced in prenatal yoga. And one of the things to remember, and which ACOG also supports, is to avoid hot yoga or hot Pilates, which is not really recommended during pregnancy. So exercise precautions with women with pre-existing diabetes. So one of the things you want to remember for someone who is diabetic or type 1 diabetic, who's basically pre-existing, is when blood glucose is more than 250 milligrams per deciliter, check urine ketones. And more than likely they need more insulin. So if positive, do not exercise until negative. And you want to definitely call your medical provider for advice. And when blood glucose is about 100 to 120, you don't need any extra food. You can call the medical provider for advice. When blood glucose is less than 100, kind of not low, but it could be a predictive low, eat a carb snack before exercise. So this, which I would say to anybody who is not pregnant or not diabetic, or maybe diabetic, not pregnant, going to exercise, to make sure that you eat a carb snack before exercise. And also, I'm not going to go into very details, but it depends on what kind of exercise you do as well. If you're doing a cardio and a sprint training, you want to make sure you have a starch and a protein together. And if you're doing any resistance training, it's more protein. But definitely, since a woman is pregnant with diabetes, would want to have a carb snack before exercise. And when the blood glucose is less than 70, treat for hypoglycemia. And we talked about the Rule 15. And exercise when the blood glucose reaches target level. Now, moderate physical activities is walking briskly about 3.5 miles per hour, and bicycling less than 10 miles per hour, or general gardening like raking, trimming shrubs, dancing. Well, it depends on dancing can be moderate or intense. So just a moderate, just like a Zumba kind of a style, or just kind of a very low impact to a little high dancing, golf, walking and carrying clubs, water aerobics, canoeing, or tennis with doubles, not singles, is much more intense. Now, the vigorous physical activities is running and jogging, 5 miles per hour, walking very fast, about 4.5 miles per hour, bicycling more than 10 miles per hour, heavy yard work such as chopping wood, or I wonder why they would do that, probably not, and swimming, freestyle laps, aerobics. Some of aerobics could be low impact as well, but it depends. It's a high intensity aerobics where there's toning and cardio, everything is kind of mixed up, and basketball, competitive, and tennis, singles, all considered vigorous physical activities. Now, some of the warning signs to stop exercise as supported by ACOG is chest pain. Like we always say, not just during pregnancy, but anytime you get chest pain, tightness in your chest, per se, or nausea, or dizziness, headache, regular and painful contractions, vaginal bleeding, amniotic fluid leak, calf pain or swelling, muscle weakness affecting balance, and shortness of breath before exertion. These are all the warning signs that you want to not really push yourself and stop. And if you're having any of the issues constantly, obviously, you want to get in touch with your OB to see if he or she would put you on some kind of a restriction at that point. So now switching gears to part 2, which is postpartum, diabetes prevention and breastfeeding. So after all that thing is done and the woman has successfully delivered the baby, now how do we prevent diabetes? Because the risk for diabetes or pre-diabetes runs a little bit higher with someone who had diabetes during pregnancy. And we want to make sure we encourage a lot of breastfeeding. And I'll talk more about that. So this slide shows the diabetes prevention and weight loss. So goal, what we want postpartum is about 5 to 10% of weight loss. And the DPP study goal is about 5 to 7%. And most of the women I've seen, they lose weight, but I also emphasize the fact that the first 6 months where it's really crucial, where you have to focus on losing the visceral fat. After that, it gets a little harder, so meaning in terms of effort, you have to double up the effort to kind of lose that weight. At least about 30 minutes of moderate intensity physical activity 5 times a week, right? The general recommendation by Surgeon General is all 7 days, but 5 days is perfect. Understandable that you have a little one, you have a baby, and there's a lot going on. So at least a 30-minute of moderate intensity. We're talking about not after a meal, it could be any time during the day. And any physical activity that helps get your heart rate up. It can be anything that the examples we talked about. Can be 10-minute sessions throughout the day. So accumulative exercise does help rather than no exercise. Many times women say, oh, I really could not do the 30, 40 minutes. Maybe I'm going to do it from tomorrow. And by the time they realize they're putting it off, it's already been like months before they exercise. So I would say any accumulated 10-minute sessions would be okay. So whenever you find time, add in the 10 minutes. So if you did 3 sessions, you already got 30 minutes for the day. Now, breastfeeding for women during pregnancy. The American Academy of Pediatrics would suggest human milk is the preferred feeding for all infants, including premature and sick newborns, with rare exceptions. Exclusive breastfeeding for the first 6 months is highly recommended, and support for breastfeeding for the first year and beyond. So 6 months is what highly recommended, but preferred is at least a year or more, and beyond as long as mutually desired by mother and child. So I know a lot of the women are extremely good. They do a year or 2 years. I think I've had known, which is probably a very rare case, who was feeding her baby child actually till 7 years, which was like, oh, okay. Not sure why that happened that long, but 6 months again for sure is recommended, strongly recommended, and preferred is at least a year and beyond as mutually desired. And the World Health Organization recommends continued breastfeeding up to 2 years of age or beyond. Now, exclusive breastfeeding, like we talked about again, it's a repeat, sorry. Breastfed infants are leaner. So what are some of the benefits of breastfeeding? So there's a lot of research on this, and it shows that breastfed infants are leaner. It decreases the incidence of diabetes in the offspring. So we have seen that breastfed kids have a decreased risk for diabetes and obesity during their lifetime. And they tend to have fewer infections in infants compared to someone who's formula-fed. You can see primarily a lot of the babies coming out with most commonly like the ear infections and other infections. And the breastfed infants are normally or tend to have higher IQ than who are formula-fed. Now, women with diabetes can successfully breastfeed with proper education, planning, and support. So like every woman is different. It depends on the type of diabetes, and also depends on a lot of other things like cultural aspects and fear of, you know, a lot of issues at home, personal, and, you know, their work schedule. So everything has to be really individualized, but at least pushing at least for the first minimum 3 months to 6 months and 1 year, which is preferable. Now, why breastfeed? I think a lot of you probably know this over and over again, like it's been taught, but just kind of to go over beneficial effects. Breastfeeding has beneficial effects on glucose and lipid metabolism in women. So you can see when people are, women are breastfeeding, their sugars tend to look better. And I've seen once they wean off, it just kind of makes that dent. And it's like, whoa, what happened? My sugars are up. So because when you breastfeed, your sugars are going out of your system in the form of milk. So when your sugars are going out, your calories are going out. So it has a positive effect on glucose lowering. And also your lipids, and also on the weight, because you're losing the calories, you tend to lose weight. But I'm going to talk about the weight shortly. It helps with the cholesterol management too, because you're mobilizing a lot of the fats to breast milk. Lactation assists with weight loss postpartum. Like I said, when you're breastfeeding, it helps with shrinking your uterus. And when you're mobilizing the sugars and lipids out of your body, it helps you lose weight. Recommendation, we always say, we advise half a pound to 1 pound of weight loss when you're breastfeeding is considered safe without interfering with their breast milk production. But I normally advise women to be not in a big hurry to lose all the weight. It's not like you want to lose 5 pounds in 5 days. Then you will have problems with the breast milk production. So want to make sure that it's slow and steady. But we still do, yes, women can still lose weight when they're breastfeeding and still not have an issue with milk production. Now, in the Nurses' Health Study, 1 year of breastfeeding decreased the diabetes rate by 15% in the normal population of women, which is pretty significant. And breastfeeding also helps reduce or delay risk of subsequent diabetes in women with the GDM history, for sure. Now, early breastfeeding appears to reprogram the eating centers in the brain. So these are some of the facts that is put in the slide. So this is very much talked about. So breast milk contains hormones, neuropeptides, and growth factors that may affect growth development and self-regulation of food intake. So leptin, which suppresses the appetite, and infant, and which is high in breast milk, and infant serum leptin is positively correlated with maternal concentration. So again, like that's one of the reasons the early breastfeeding definitely appears to reprogram the eating centers in the brain. And a review of clinical literature concluded that early cow's milk exposure may be an important determinant of subsequent type 1 diabetes in the infant and may increase the risk by time and a half. So babies who are bottle fed, formula fed, or who get early cow's milk, some of them could be carriers of type 1 diabetes. They just need a trigger. And the cow's milk just could be a trigger for them to be, for the type 1, risk of type 1 in infant. And the other studies have identified foods such as gluten or wheat as trigger for type 1 diabetes. The Thema, Indian, and Finnish studies demonstrated 3 months of breastfeeding reduced the lifetime incidence of diabetes, type 2 diabetes by about 13%, which is pretty significant. Now, talking about benefits of breast milk versus infant formula. So I think this is a classic slide. I think as a provider, if you're talking, if you talk in many conferences or many things, I think pretty much all of us have used this slide. So it keeps building on. So if you see breast milk and infant formula, both of them are water and protein and carbohydrates and fats and vitamins and minerals and fatty acids, DHA. And you can see now the breast milk benefits building up. It has all the protective enzymes, the growth factors, hormones, antibacterial factors, antiviral factors, and anti-parasitic factors. So there's a lot of good benefits to, so this is that slide, what I was talking about, this one is a really good one to focus on encouraging or motivating women to breastfeed. All right. Sorry, I have to go to the next slide. Bear with me. Okay. So breastfeeding, how is it good for the mother? It helps improve glucose metabolism. We all know that. So there's non-insulin mediated use of glucose by mammary glands to synthesize lactose. So the mammary glands really does not need insulin to burn off the glucose. So that's one good, education point for the mom, saying, hey, your glucose is going to look good if you give them the fact as to how it's going to make it look good. And increased insulin sensitivity due to increased prolactin and decreased estradiol. Now, and there's also improved beta cell function with 3 months of breastfeeding in women with GDM. So, so women who at least do the 3 months, so you can focus a lot about saying at least what are the benefits. So it helps women really improve or lower the risk of having prediabetes or diabetes in their lifetime. Now, how is breastfeeding good for offspring? Infants tend to be leaner with breastfeeding, and there's an inverse relationship between breastfeeding and the development of obesity. So, and formula fed, like we have talked about, if someone had babies were done formula, there are high levels of leptin in breast milk, and there's a lot of connection with that, with the obesity part of it. And the formula-fed infants produce more insulin because of lots of the sugar, or the composition of the formula milk, or the formula per se, and a hyperinsulinemia retards the lipolysis, breakdown of the fat, and enhance fat deposit. And so formula-fed infants over time see increase in their weight, and it could put them at risk for obesity. Now, this slide is showing the risk of not breastfeeding for infants and mothers. So if you can look at the left side where it talks about the infant, so one of the risks for not breastfeeding for infant could be diarrhea, gastroenteritis, enterocolitis in preterm infants, or sudden infant death syndrome, asthma, pneumonia, ear infections, and bacterial infections, childhood obesity, and type 2 diabetes. So it's just the same thing like we focused that glycemic control during pregnancy is a predictor for either building up is a risk for or predictor for the risk of diabetes and obesity for the offspring in the lifetime. Is the same way risk for not breastfeeding, you're putting the baby at risk for being obese or having type 2 diabetes in the lifetime. And childhood leukemia. And also for the mother's side, retention of gestational weight gain. like I said, most of the time women do lose some amount of weight, but it's a lot of the things, lifestyle change. They've been waiting for 9 months to eat what they want to eat, and some of them lose it, but they gain it back. So that's when you have to focus on the first 6 months. Is so crucial to kind of lose that weight. And breastfeeding, like I said, it helps you shrink the uterus, helps you mobilize the sugars and the fat, and helps you lose weight on a normal basis. Postpartum depression has been researched, and very well researched, and it's been factored in that postpartum depression is one of the facts of not breastfeeding the infants, and also risk for type 2 diabetes and metabolic syndrome, perimenopausal breast cancer, or ovarian cancer. So these could be some of the good pointers, I would say, could be presented to women at your 37 weeks or 38 weeks when they're actually going to be discharged from the program, and you're talking to them about postpartum diet or breastfeeding, to give some facts about breastfeeding, pros and cons, so that kind of motivates them a lot more. So now, breastfeeding in the hospital. But we want to definitely make sure when they're in the hospital, you want to increase breastfeeding within first hour of life, and for every hour for first 4 hours, and or feed on demand when possible. I know women are going to be really tired because they breastfeed, and every time they breastfeed, the risk for dehydration is high. And if nursing is delayed, most of the women do have breast pump, and they can use the pump to establish the milk supply and prevent engorgement. And if you're in the hospital and if you have issues with breastfeeding, always ask for the lactation consultant referral. And I think it's wonderful that they come by the side and they help you out with any issues that you might be having breastfeeding your baby. And many of the clinics, when you go back, or the hospitals after discharge, they have support group, breastfeeding support group. Like where I work in my practice, there's one day in a week where they have breastfeeding support group, where the licensed lactation consultant is helping the women having problems with breastfeeding, and it's a free and a walk-in kind of a clinic, and happens for 2 hours or so, which is something really nice. So if you don't have that kind of a program or support group in your hospital or facility, maybe it's a good idea to think about putting one together, which helps women out. Now, breastfeeding with GDM, maternal diabetes and obesity can delay the onset of lactogenesis. So people ask me all the time, is it type 1 diabetes, or it's type 2 or pre-diabetes? What kind of diabetes really delays milk production? So it's no specific diabetes that we're talking about, but it's maternal diabetes. So meaning uncontrolled sugars during pregnancy, no matter what kind of diabetes, and obesity. So if you were obese before pregnancy, and then you kind of failed the test and you had diabetes during pregnancy, that put in together can increase the risk of delayed lactogenesis. But we have to encourage women that it's not that most of these women cannot breastfeed. Most of them can, but it's all about bottom line. That's when we're focusing. It's all about control of sugars during pregnancy. Dictates a lot of the lactogenesis process. And delayed milk production can lead to lower rates and shorter duration of breastfeeding. So if women had uncontrolled sugars during pregnancy, that can delay lactogenesis, and that is a fact for women to easily give up. And all that good part of the components that you find in the milk the first 3 months is not being passed on to the baby. So that's one of the other points that you want to talk about, not at the end of pregnancy, but in the first class, I would say in the class, to emphasize why are we talking about you following the diet and exercise. It's because it helps you in so many different areas. Now, immediate beneficial effects on glucose tolerance of postpartum women. I mean, you can see the effects. Usually, I tell women the moment, I don't really have to tell women. They just say, oh, my sugars are looking great. I'm breastfeeding. So there is immediate beneficial effects that you can see on the sugar levels. And also caloric utilization. And so when you're breastfeeding, the milk gone from your system is the sugar gone from your system. So I do tell women it's almost like you're on a diet or almost like you're running and you're expending your calories. By breastfeeding, you're expending your calories just by sitting there and breastfeeding a baby. And in turn, you can still lose weight, but definitely you're gonna have to focus with the dietitian that they still need to be eating more than what they're eating during pregnancy to support breastfeeding. Because that's one of the facts for if you didn't eat enough, it can interfere with the breast milk production. And weight changes. Obviously, when you breastfeed, like it's like a repeat, but then like I've said, it helps you shrink your uterus and you mobilize your fat in the sugar stores, and it helps you lose weight in a very nice and a steady fashion without interfering with the breast milk production. Now, breastfeeding with PCOS. So this is a question, and I would say there are research articles on this, but there's not a whole bunch of research articles when it comes to breastfeeding with PCOS. But one of the things that, based on studies, you can see a small percentage of women, about 2 to 5%, have not been able to make enough milk to support a baby. About 33% of women with PCOS report insufficient supply, while 20% report problematic overproduction. But based on studies, it is thought that PCOS may possibly interfere with the hormones required for the breast milk to develop milk-producing tissue. So women with PCOS have low levels of progesterone, which is needed for alveolar growth and breast tissue development. So the insulin also plays a role in the milk production. So having this insulin resistance with the PCOS may contribute to lactation problems. So addressing any underlying hormonal imbalances with the medical provider would be important, so appropriate interventions could be taken. Now, what else does happen, like we talked about, touching a little bit more on PCOS, high levels of androgens can slow down, regulate estrogen and prolactin receptors. So high levels of androgens can downregulate estrogen and prolactin receptors. And high levels of estrogen could inhibit milk production. So that's exactly kind of what is happening with someone with PCOS. And these women with uncontrolled diabetes may not make enough milk. So if this is due to insulin resistance, could hypothetically cause lactation problems. But like I said, it does not mean that someone who has PCOS, of course, the risk is a little bit higher of milk production, but controlled sugar during pregnancy still the women with PCOS can successfully breastfeed. Now, someone with type 1 diabetes and breastfeeding is strongly encouraged breastfeeding. And maternal hypoglycemia is associated with lactogenesis, delayed lactogenesis. Like I said, it's not like a particular type of diabetes. Now, glycemic control should receive much attention, especially with someone with type 1, because there are a lot of episodes of hypoglycemia could happen. And this hypoglycemia induces epinephrine release, which causes temporary decrease in milk production. And hypoglycemia is most likely in this population likely to occur within an hour of breastfeeding. So the important time so it's very, very important to focus to check your sugars, focus on the education point to check sugars frequently to monitor any hypoglycemia. And so recommending a snack before or during breastfeeding is highly, one of the things that I would highly recommend. And as a dietitian could go over the kinds of snacks which would help them. And a need to adjust. So these population might need to adjust or eliminate nighttime NPH or insulin to avoid nocturnal hypoglycemia. So, this is very individual depending on what dose the patient is on, what kind of insulin the patient is on. So the risk for nocturnal hypoglycemia is higher. So at that point, they might have to wake up many times in the middle of the night to check the sugars as to what it looks like. So when they're up and up in the night feeding the baby, it may be a good time to check the sugars to realistically see what it looks like. And based on that, they could adjust their insulin dose. In general, the basal insulin rates may be decreased when breastfeeding. So even somebody's an insulin pump or so, or just taking sub-Q, we want to make sure that the person, so you might want to work with the CDEs or the doctors, medical providers to work with what percentage of basal rate decrease are you talking about, so to eliminate any kind of hypoglycemia. Recommended blood checks at pre and post meals and bedtime and 2 and 3 a.m. is highly recommended. It's highly beneficial to prevent any low sugars. And Sweet Success recommends 1 to 2 hour postprandial blood sugar level to be between 150 to 155, not more than that during breastfeeding period, because higher levels. So women ask me a lot more times, what if my sugars are really high and I'm breastfeeding? Does it affect the baby? So there is research on that, and I would say yes. Higher sugar levels, maternal higher sugar levels during breastfeeding can contribute to adverse outcomes for offspring, such as reduced glucose tolerance and increased body weight in future. So if your sugars are constantly high when you're breastfeeding, that could be a risk for the offspring. So you want to make sure that your sugars for someone who's has type 1 diabetes is much more within this range. The type 2 diabetes and breastfeeding is, again, very strongly encouraged. Major concern for type 2 diabetes patients being the use of oral hypoglycemic agent, which I'm going to talk about shortly, and their effects in breast milk. And the question usually is, would I be back on the medication that I was? But if I was, how does it affect the breast milk? And there's a lot of questions that I get from the endocrinologists, or mainly a lot of endocrinologists or the OBs is like, what do we do? Do we leave them on that metformin, or we take it off? I'm going to touch base a little bit in the next coming slides on that. So the blood glucose goal is the same as we talked about for type 1 diabetes patients. Recommendation is to check blood sugars at fasting, 1 to 2 hour postprandial, and bedtime and occasional 2 to 3 a.m. Now, avoiding maternal hypoglycemia. One of the things we talk about is if the blood glucose is less than 100 before breastfeeding, take about 15 grams of carbs and 7 grams of protein as a snack. And it has to be really, really individualized, very individualized depending on a history of sugar trending, or the pattern of sugars. But if your blood sugars is less than 100 after feeding, you can see I'm talking about before and after. So if it's less than 100 after feeding, consider 15 grams of snack if insulin on board. And hypoglycemia causes, like I said, again, release of epinephrine, which can cause temporary decrease in milk production. So if you've had high rates of hypoglycemia during your breastfeeding, and you're wondering why your breast milk production is tapering off, it's because of the release of epinephrine, which is probably doing that. Now, oral medications, this is one of the topics that they talk over and over again, and still a lot of debate on that and a lot of talk about this. So the American Association of Pediatrics judged tolbutamide as a first-generation sulfonylurea to be safe during lactation. So it is recommended that a woman with type 2 diabetes who is unable to maintain normal glycemia through diet and exercise alone to continue with insulin during lactation period. However, oral hypoglycemic agents can be used. So, like I said, the AAP states that the tolbutamide is considered safe during lactation. Even though small amounts of this crosses into breast milk, it has been in use for a number of years, and to date, there are no adverse reports reported in literature. And studies shows that very small amounts of glipizide and glyburide passed into breast milk compared to metformin, and both were found compatible with breastfeeding. So there are studies that show metformin crosses into breast milk. So most of the medication do cross breast milk, but they cross in small amounts. And so the metformin amounts are very low in concentration. Is not considered metabolically active. According to a small study published in 2005, neither glyburide or glipizide were detected in the breast milk, and hypoglycemia was not observed in 3 nursing infants. So basically, it's not a large study for us to say, and I do tell this to the women that there's not significant amount of studies done on this, but from whatever studies that were done, the conclusion from the studies usually have concluded that all hypoglycemic drugs to be compatible with breastfeeding. And for metformin, which a lot of them you've seen women breastfeeding want to be on, or they're considered to be on, is per study is considered safe during breastfeeding. Only the one long-term study, which we talk about now, on infants, which was done for 3 to 6 months, suggested also there was no significant difference in height or weight or motor social development. So a lot of debate, so it's good to be updated on that, and you see a lot of conferences and a lot of workshops do talk about this updated information. Now, the other medications that we're talking about are, which is the one recommended during breastfeeding. So if you look at the left-hand side, the ACE inhibitors are not recommended in the first 2 weeks of life. ARBs, not studied yet. Beta blockers recommendation varies depending on the specific drug. Calcium channel blockers is approved by AAP, and levodopa is approved by AAP, and statins are not recommended during pregnancy. This is kind of a nice little cheat sheet to have for providers when they are talking about medications during breastfeeding. So nutrients during lactation. So dietary, people ask me, what particular nutrient should I be really consuming a lot more to produce, to help with breast milk production? So the dietary protein and carbohydrate has no major effect on breast milk per se, or even breast milk production. Some fats, it's been seen that fats, some effect by diet related to type of fat and maternal body composition. So increased saturated fatty acids and unsaturated fatty acids in diet increases the concentration in breast milk. And the diet does not seem to alter the concentration of cholesterol and phospholipids in human milk either. One of the things has been noted that diet, so we always tell women to be eating more than what they ate during pregnancy because of the breast milk. But if they were not breastfeeding, I would not worry about increasing the calories. That point, they can focus a lot more on weight loss. But diet consisting of less than 1,500 calories when women are breastfeeding have been shown to decrease milk volume. So in general summary, we would say, focus on eating more. So I tell women there are some things that could interfere with some factors that could interfere with breast milk production. One of them being if you're eating less and if you're not getting enough sleep, which is probably going to be like a history after the baby's gone. But I say sleep whenever the baby's sleeping. So not enough calories, not enough sleep. And if you try to lose all your weight in a day, trying to lose rapidly, that could interfere with breast milk production. Or if you don't breastfeed, you decide not to breastfeed your baby for a while after you deliver, and let's say after 4 weeks you decide you want to breastfeed your baby, you're kind of drying up. So the 4 factors: the caloric intake, increasing calories, making sure you're getting enough sleep, and making sure you're losing weight safe way in a safe fashion, like a 0.5 pound to 1 pound per week, and you start breastfeeding right after the baby is born. These are the factors that would help maintain the breast milk production rather than interfering, lowering it down. So recommended women aim for, like I talked about, 4 or 0.5 pound, 4 pounds per month, or 0.5 pound, 4.5 pounds per month. But just a normal rule of thumb, 0.5 pound to 1 pound per week is safe enough to lose weight during breastfeeding. Now, weaning off. So when you wean, when women wean babies off breastfeeding, that's when it comes as a big jolt. It's like your weight starts to go up and your sugar starts to go up. I was like, oh my God, where did this come from? So now that when you're weaning off, there's not enough mobilization of sugars and fats, you tend to not, mobilize anything, so you're not really losing any weight, and you tend to start storing. So so weaning basically reduces calories to prevent weight gain. So when you wean off, normally I tell women, if you decide to wean off, make sure you're weaning off of, you're decreasing the caloric intake that you had increased for your lactation as well. And at that point, it is going to be very individualistic depending on your height and weight and what weight you started before pregnancy and where are you right now. So I would highly recommend women to reach out to the dietitian, make an appointment, and if you want to lose weight, they can help you out with a diet guidelines. And may need to readjust medication. So when you wean off, your sugars are probably going up a little bit, especially for someone I'm talking about the pre-existing diabetes. So they might have to readjust the dose of the medication. Now, we're kind of getting towards the end of my talk. So these are some wonderful resources for breastfeeding support. And I would highly, highly recommend all these, like the WIC and one of the good ones in California Department of Public Health, and all of them, the Comprehensive Perinatal Service Program. And we have the websites here, and they have a lot of good info and a lot of training or maybe webinars even for, and the handouts to give out to women. So I would highly recommend the providers to make use of these resources for breastfeeding support. To summarize, exercise. So we talked about today about exercise during pregnancy, and we talked about postpartum recommendations for breastfeeding. So to summarize, exercise, we highly recommend at least 15 to 20 minutes post-meal with 60 minutes of daily total, which is acceptable. So, but focus a lot on 15 to 20 minutes post-meal. And breastfeeding is recommended definitely for 6 months, but preferably to 1 year or longer. And goal of 5 to 10% weight loss postpartum. Remember, we're talking focusing a lot more in the first 6 months. It's very important that you keep a goal of 5 to 10% of weight loss. It helps you with your glucose control and prevents the risk of diabetes or pre-diabetes or recurrent GDM in the pregnancies later. And avoiding diet less than 1,500 calories during lactation. So I would suggest definitely eating more, but specific amount of calories that you need to be on. I would follow that up with the dietitian. So maintaining the postpartum appointment with the dietitian or the CDE is highly recommended. And that's where they talk about the postpartum diet and postpartum tests and breastfeeding and how is it going with the infant feeding. And also, if your blood sugar is less than 100, remember, before breastfeeding, consume 15 grams of carb and 7 grams of protein snack to avoid any kind of a maternal hypoglycemia. So maternal hypoglycemia should be highly focused on, especially for someone who has got pre-existing diabetes. So lastly, I would thank all of you for taking this time and hope all of you have learned a lot from here and enhanced your knowledge on exercise and breastfeeding, and hopefully will be applying in your practice. And again, thank you and have a wonderful day.